lecture, we're going to talk about just some quick practical ethics for residents. I would like to give a disclaimer before I start. I apologize if there's any heavy breathing over this recording. My dog refuses to leave my lap right now, and I'm trying to get this done. So that's Reese for everyone if it sounds a little weird coming through. Sorry. So what we're going to cover in this lecture, just a few things going through DNR status. Probably cover a little more of this in another lecture that I'm doing regarding kind of end of life and geriatric care. But in addition to that, we'll cover a little bit on withdrawal of treatment, informed consent, competence and decision-making capacity, futility and unreasonable requests, organ donation, and then when to consult ethics, because we don't do it that often, but there are some cases in which we should probably have them on board. So the first one in DNR, whenever you're going to discuss DNR status with a patient, it's always important to discuss comfort and therapeutic measures first, and those should be emphasized. So we're seeing a patient in the ER and seeing them for whatever sort of surgical issue or traumatic issue we're seeing them for. We always want to discuss what we're going to do for what they came in. And then at the end of that discussion is probably more when bringing up DNR status or code status should be addressed. You don't want to walk into a room and ask the patient if they're DNR-CC before kind of asking about the rest of their problems. And then the other important thing here is that who can make this decision. So obviously the patient themselves is going to make this decision most of the time. There are plenty of times where there are advanced directives involved in our older patients, and in those advanced directives, a lot of times you can find their code status orders or their wishes. And then kind of the third case scenario or guardians or healthcare power of attorney, family members, whoever is kind of the designated decision maker for the patient. If that code status needs to change during a hospitalization or when you're seeing the patient, that's kind of the order we go in as far as who can change those orders. So if you're going to discuss and then document a change in DNR status, there are a few things that you should be sure to do. So number one is document your DNR discussion and change of code status in your note or put in a brief note to be sure that it's noted that you had this discussion with the family, what the discussion was, and that they elected to change code status to whatever. It may be from DNR to full code or from full code to DNR-CC or CCA. So you want to make sure that you document that you had that conversation and kind of the results of it, not only for you, but probably for the rest of the providers and nursing staff taking care of the patient. Be specific when talking about this with the patient to avoid misunderstanding. As far as DNR status, Ohio has 3 different DNR status or code statuses. So you can be full code, DNR CCA, or DNR CC, and those all have kind of a little bit of different nuances to them. Again, that's the kind of the differences in DNR status. I'll talk in another lecture. But you want to be very specific when discussing those with patients' families so they don't misunderstand what they're choosing. And then also, if you're going to change the code status, be sure to let the nursing staff know that, hey, this patient is changing from full code to DNR. And especially in Ohio, I think because of our code statuses, sometimes things can get a little confusing. But DNR does not mean do not treat, especially in our DNR CCA patients. They are kind of full treatment up until the point of code, and then DNR CC are comfort care, so they're still receiving care to make them comfortable at end of life. It doesn't mean we're necessarily treating their medical problems, but it doesn't also mean that you're not giving any sort of or providing any sort of medical care to them. So just kind of some notes about CPR that I think are helpful to know, especially when discussing DNR status with patients. So CPR was developed in the 1960s, and it was developed for sudden cardiac arrest in previously well individuals. So this was kind of the normal person walking down the street who all of a sudden coded. That's who CPR was developed for. Obviously now it's spread to pretty much anyone who comes into the hospital as a full code, whether or not that patient's 95 and has 8,000 medical problems on their chart, or whether it's the 22-year-old that was hit by a car. Everyone's kind of getting CPR. So it was initially developed only for those healthy individuals. Only about 15% of hospitalized patients in whom CPR is attempted actually survive until discharge. And the pre-arrest condition is the most important predictor of success. So kind of makes sense that your 95-year-old lady with all kinds of medical problems probably isn't going to do well if you can even resuscitate them after a code. So not very surprising there. The best results that people obtain with CPR are in witness arrest and with a ventricular dysrhythmia, and not PEA. And it's in those people who are resuscitated within 5 minutes. CPR is successful in about 25% of arrests from a drug reaction or an overdose. And then kind of other things I think to discuss with patients when you're discussing kind of DNR and codes, about 25 to 50% of CPR patients have rib fractures, sternal fractures, except for aspiration pneumonias, mediastinal hemorrhage, and pulmonary edema. So that's even if you are able to get them back, they're left with a lot of these sequelae afterwards. And actually up to 10% of people who are resuscitated from arrest end up in a persistent vegetative state. So they end up with an anoxic brain injury as a result of their arrest, and the rest of their life is spent in this persistent vegetative state. So who to talk to about CPR? Pretty much everyone that we see who comes through those hospital doors, especially down in the ER, is someone to at least kind of broach code status with. They mentioned that people with planned outpatient surgeries may be the exception. So the patient you're bringing in just for outpatient lap chole or something, or hernia repair, you don't necessarily need to discuss code status with them. But anyone who's coming into the hospital who needs to be admitted because they're sick, and especially in those older individuals, is probably someone we should at least broach the discussion of DNR status with patients. Especially critically ill patients or those with serious chronic medical conditions. So a lot of the people we're taking care of have a lot of other medical comorbidities that will affect how well they do from their current surgical problem. So those are patients that are probably important to at least broach the subject with. And if there is concern that the patient will lose decision-making capacity, so do not wait until someone is no longer decisional. If someone comes in and they look pretty sick, but they still have the ability to make their own medical decisions at the time, don't wait until all of a sudden this patient is on the verge of coding and you're intubating them and you're putting lines in, you're starting them on pressures or vasopressors. You should probably have discussed code status prior to all of this happening, and when that does happen, you're kind of kicking yourself afterwards saying, man, I wish we would have talked about this sooner. And the other thing I think is a lot of patients will elect to stay full code, but you may be the first person that kind of brings up this subject to patients, and then it at least gets them and their families thinking about it and discussing this, so that maybe if the time does come, family members have already talked about it. Sorry, having computer problems here. It's thought that with family members that DNR implies a reasonable degree of success. So actually, some providers have argued for the change in name to do not attempt resuscitation. They think that DNR, or do not resuscitate, means that we're going to get them back every time. So it's important that family members realize that just because we are attempting resuscitation in no way means that we'll even be able to bring the patient back. They recommend avoiding phrases like, do you want us to do everything? And do you want us to restart your heart? Sorry about that typo. If it stops. And so those phrases kind of can mean to family that we're not going to take care of the patient. And so you want to be very specific about continuing medical treatment. However, we will not go and above and beyond to attempt resuscitation should your heart stop on its own. So the next thing, talking about full code versus futility. So a physician is under no obligation to provide treatment that he or she deems not medically indicated. At some hospitals, a DNR order may be written on the basis of futility, that the physician believes that this patient should have a DNR order just because of their other medical comorbidities, that they are unlikely to survive a resuscitation attempt. In those places, they require a second staff member to justify this judgment in the chart. I do not believe that Mount Carmel has this, and I think it would be very difficult for you to argue to do this. But just so that you're aware, it is out there that some hospitals do allow this. So another thing to touch base, especially with our patients, is DNR in the OR. A lot of times anesthesiologists will talk about code status with patients prior to taking them back and putting them asleep. A lot of times, because an arrest that occurs in the OR may not be related to underlying disease, and it may be easily managed with drugs, and oftentimes don't require extensive or long codes to revive the patient. And so oftentimes DNR policies that, or patients that have DNRs, are often changed to full code in the OR and returned to DNR post-op. The important thing is to be aware of this, especially in sicker patients who would like to be changed back to DNR. You have to make sure that that reverts in the chart, because I know there have been some times where we found a few days later that anesthesia switched them over to full code and then never switched them back. And so you just want to make sure that your patient's wishes are being followed, and then that gets switched over in the chart. So the next thing that we're going to talk about is withdrawal of care, and how that discussion can kind of go with families. So there's an authority for withdrawal of care. Kind of number one, as you'll see on all of these lists, is the request from the patient. So who can withdraw on a patient? The patient can request themselves. They don't want any more treatment. They want their feeding tube stopped or something else. The patient always kind of has their final say, as long as they still have medical decision ability. That kind of next layer, so if the patient is unable to request, if they have preferences expressed in their advance directive, you're to follow those regarding withdrawal of care. After that, as a lot of our patients don't have advance directives, comes from judgment of a guardian or healthcare power of attorney. Next would be agreement by loved ones. So if there isn't one specific family member that's selected as healthcare power of attorney, it's an agreement of those present. A lot of times it's the patient's adult children who are making that decision. If there are no family members around, it goes to then agreement by close friends. And then in situations of social isolation, which are relatively rare, care providers can be able to determine what's in the best interest of patients. So there's a important discussion of difference between withdrawal versus withholding treatment. And so a lot of times it's psychologically easier to not start treatment than it is to stop the treatment. A lot of times family members have this feeling of continued obligation. I think the most common one that we encounter, or at least that I have, is feeding access and tube feeds. A lot of times people will be started on tube feeds after a stroke or some other insult, and family in the acute setting elects to place a peg tube or a feeding tube and begin tube feeds. However, down the line, it becomes very clear that this patient is never going to get any better or recover function, and then it becomes a very difficult discussion between family members and family and providers regarding how long do we continue to provide tube feedings, which are kind of the only thing sustaining this patient, and that it's artificial nutrition at that time. They do offer that sometimes it can be useful to offer a limited time trial if this is something that family is concerned about. So maybe stating we provide the patient tube feeds for the next 2 months or 3 months, and if the patient doesn't have any reasonable success, then that's when they decide to withdraw tube feeding. So that can sometimes be helpful to patients' family members to have some sort of end goal when starting this treatment if you're not sure whether or not it will help. And importantly, there were 2 court decisions which separated artificial nutrition through a feeding tube from normal ordinary care. And the court stated that this procedure is equivalent essentially to artificial breathing using a ventilator. So there was, for a while, some discussion that it was inhumane to stop tube feedings or artificial nutrition. However, it's now viewed as same to withdrawing on a ventilator. And so just to kind of go over what it involves, withdrawal of nutrition and hydration, patients and or the healthcare power of attorney or decision makers can choose to withdraw or withhold nutrition or fluids. When you're withdrawing on patients and withholding both nutrition and fluids, death usually occurs in 10 to 14 days. If you withdraw nutrition only and continue to give the patient fluid support, either through flushes through their tube or IV or significant IV fluids, it can take many weeks for the patient to die. It is noted from hospice care facilities that patients are rarely uncomfortable, and I think I touch on this again a little bit later, and that ice chips and oral care provided for comfort are usually all the patient requires. They do note that if IV access is needed for palliative medications, a KVO rate will not prolong the dying process significantly, so that is still acceptable to provide them with minimal IV fluids in order to facilitate their medication administration. So the effects of withdrawing, just what to expect with patients who you are kind of, or withdrawing tube feeds on, not that we do this all the time, but just for everyone to know. So patients usually develop a hypernatremia, azonatremia, and then also increased endogenous opioids. And this actually leads to a mild euphoric state and actual possible sedative state. So through these hospice observations they're just observations listed from a hospice study, that patients usually at the end of life voluntarily stop eating and drinking, and they do not tolerate substantial volumes of enteral tube feeds and develop severe nausea. So when the patient is nearing end of life, even if we continue to try to give them their normal volumes of tube feedings, they don't tolerate them well, and it can lead to more distress with nausea. When they're given normal fluid replacement, patients actually develop fluid overload in end of life, and hospice patients almost never report being hungry. They do note as well that dehydration can help with less vomiting, diarrhea, and secretions, and help making the dying process a little bit easier on patients. So I know we always think of withdrawing tube feeds and water and how horrible that must be, but actually a lot of patients don't tolerate it, and it can help with some of their other symptoms as well. So it's important to distinguish medical treatment versus supportive care, and it's noted that healthcare professionals are not obligated to provide specialized life-sustaining treatment to every patient simply because the technology is available. And we'll kind of get back to this on futility and unreasonable requests from family members, but just because you can provide some sort of treatment for the patient doesn't mean you should or you have to. And so just kind of keeping that in mind going forward. So the next thing we'll talk about is informed consent. It's something we do almost on a daily basis, so I thought it would be good to review. First, elements that are required to have informed consent. Patients must have a clear understanding of the disease process, their prognosis, benefits and burdens of treatment, benefits and burdens of alternative options, and the likely effect of no treatment. So those are things you should discuss with every patient when talking about any sort of procedures or surgeries that you're planning. And the other element of that is consent. So the patient must voluntarily and be able to give their own authorization to proceed. So obtaining consent, who can give informed consent? Of course, the patient with decision-making capacity can sign their own consent forms. You must have an adequate disclosure of information. Patients must have an adequate comprehension of the information. They must be free from coercion by other either family members or friends. And then you receive actual consent from the patient. So those are kind of the 5 things in order to obtain a informed consent from a patient. There are court disclosure standards. So there's a professional standard when discussing informed consent of what a reasonable medical practitioner in the same field would reveal to a patient under the same circumstances. So you must meet those criteria when discussing any sort of informed consent. And then the other kind of standard is the reasonable patient standard. So what information an objective patient would consider material to the decision of whether to consent to the procedure offered. So when you discuss consent for a procedure with a patient, you must provide them with the same or with the medical information that any other reasonable medical practitioner would provide at any other hospital or anywhere else in the country. And then also your patient must have or must consider kind of the material to their decision. So exceptions to emergency or to informed consent. One we use often is the emergency privilege. So patient's unconscious, without capacity, no one else is present to make the decision. A lot of times these are trauma patients that we're intubating, putting in lines, performing procedures. That's when we're utilizing this emergency privilege to informed consent. The patient must be at risk for serious harm or death when invoking this emergency privilege. And then they should also be procedures that a reasonable person would consent to. So you can't be outrageous with your procedures at that time, and should always try to obtain informed consent as soon as family members or healthcare power of attorney have arrived or are available for discussions. There is another exception of therapeutic privilege. This one is extremely rare to use. I don't know that we would really ever be in a situation to invoke this one, but that's if the physician believes full disclosure would have a significantly adverse impact on the patient if they were to fully disclose all of the information. I think that one would be really hard to defend in court if that was something you were using often with your patients. There is an exception if the patient has no decisional capacity and no one else is available. So if your patient is demented or obtunded and is unable to decide and there aren't any family members around and they need a procedure, you can waive the informed consent. And then also waiver of rights. So I've had this a few times in older patients who probably are still have decision-making capacity, but they do not feel uncomfortable or they do not feel comfortable or aren't very sure of what they want to do. And so a lot of times they'll defer or discuss with other family members and have their family members help them make this decision. I have seen that one before. So getting back to decision-making capacity and competence, which I've kind of touched on a few times already in this topic, there's a difference between competence and decision-making capacity. So competence is the legal term about the ability of a person to make decisions, or the ability of a person to make decisions about their affairs. And so this is all legally based. So an adult is legally competent until a court rules otherwise. So only our Ohio court system can rule our patients incompetent. Versus decision-making capacity is a medical term. It refers specifically about the ability to make medical decisions, and the determination of whether or not a patient has decision-making capacity is made by medical personnel and does not require a court. So clinical assessment of your decision-making capacity, there are three things that go into this assessment. One is the ability of the patient to understand. And to check this, you ask patient to paraphrase the discussion had about medical illness, including diagnosis, treatment options, alternatives, risks, and benefits. So once going through, a lot of times in your informed consent process, if you're concerned about a patient and whether or not they have the decision-making capacity, you can ask them to go back through what you just talked about. What are the options? What are the risks and benefits? Number two in this is the ability to evaluate. So you want the patient to be able to deliberate essentially internally or discuss with you their thoughts and opinions and how the medical treatment coincides with their own values. You want the patient to be able to manipulate the information rationally and to be able to compare the risks and benefits. You want them to be able to give reasons for the choices made of this is why they do not want surgery versus having the surgical procedure. And then you want them to be able to maintain a consistent choice over time. So if the patient's kind of going back and forth or their reasons are constantly changing or they're kind of just not really able to provide reasons, then those are kind of red flags in the ability to evaluate. And then also the ability to communicate. So the patient must be able to state their treatment of choice or at least write it down and go through those options. So you want the patient to be able to tell you themselves and not just presume based on either them mouthing words or something else, making hand gestures. So just to go into a little bit more of informed consent with minors, we don't see a lot of minors at Mount Carmel East. Most of them, or Mount Carmel in general, a lot of them go to Nationwide Children's, but there may be times when we end up with minors in the trauma bay. And just so you're a little bit aware, this is from the Ohio Bar. This is on ohiobar.org if you're looking for any more information on this. But they classify a mature minor as someone over the age of 15 who can show a healthcare provider that he or she has enough maturity and understanding to make medical care and treatment decisions without parental consent. So this is on a case-by-case basis. The healthcare provider uses the same criteria that would be used to determine if an adult is capable of making medical decisions. So all of that stuff we just talked about, the minor must be able to do as well. And if the minor is found capable of consenting, the healthcare provider must give the minor the same informed consent as an adult received. There are exceptions. So without regard to decision-making capacity, a minor can provide their own consent for kind of the following things. So for examination purposes, gathering physical evidence and alleged sexual assault, diagnosis and treatment by a licensed physician for any venereal disease, diagnosis and treatment for any condition reasonably believed to be caused by drug abuse, beer, or intoxicating liquor. They are able to consent to be given an HIV test. They can donate blood if they're 17, and they can receive mental health treatment if at least 14 years old for a limited number of sessions or outpatient services, except for the use of medication. So they can see someone as an outpatient, but once they get medication, they must have an adult consent. And then to receive an abortion if the minor has applied to the local juvenile court and the court finds good cause to bypass parental notification. So that one does involve court process. And other things. I think it would be very rare if you ever saw that, but that's out there. So just to touch a little bit on futility and unreasonable requests, sometimes we'll have family members that request further testing or workup that we don't feel is necessary from a medical standpoint, and just going through what are your rights and the patient's rights as a provider. So medical futility is just defined as when any effort to provide benefit to a patient that is highly likely to fail and whose rare exceptions cannot be systematically reproduced. So patients asking for CT scans when they already have known metastatic cancer or other problems are likely more medical futility and not really going to guide any sort of treatment or care for the patient. So just kind of going through and trying to understand when patients or family members are making making what you believe to be futile requests, to consider these things because maybe it's more of a communication or education barrier and not just because the family members are being unreasonable. So these are important things to consider. But number one is going to be unrealistic goals. So a lot of times when we consider requests to be futile, it's kind of an end-of-life care and that the patient is not going to get better from their disease process. And it might just mean that we need to have further discussions with the patient and their family regarding their medical condition and what realistic expectations are for kind of their time left. Guilt, I think, also goes along with that one as well. Or if a family member is involved in a traumatic event, they may kind of ask for further testing in an attempt to heal their own guilt. If there's confusion regarding the plan, so if we haven't been clear enough or haven't gone over things enough with the patient regarding what our plan is for their ongoing treatment, sometimes patients may make requests that we don't seem as necessary. There may be ethnic or socioeconomic reasons behind their request. I think denial kind of goes along with guilt a little bit in that and unrealistic goals of maybe patients or family members are in denial is kind of the illness of the patient. There's misunderstanding or a language barrier. Can be difficult. We have plenty of access to interpreters at Mount Carmel, and so making sure that we can help out with those language barriers and discuss further with patients. And then also religion may come in at times when patients are making these kind of requests. So as a physician, what are kind of the grounds for refusal of requests? So number one, if the request is for something outside the scope of good medical care, if they're asking for something outrageous and you do not think that any other provider in the same position would make that decision or order that test. Obviously, if the patient or family requests something illegal, you are allowed to refuse it. Or if the request requires a doctor to violate personal and professional standards, if the requested treatment cannot be anticipated to produce any beneficial result for the patient. So a lot of times, I think most of the time when we are discussing with patients futile requests, it mostly is in the form of scans or further images. Patients are asking our family, are we going to CT the scan or CT the patient again? And it just takes more explanation of why we do not need to continue CT scans to monitor fluid collections or something else. I think that's most of the time what we've seen, or what I've seen at least. And usually if there is a significant refusal, if this becomes a area of issue with the family member or patient and the medical care team, we should offer the opportunity for a second opinion. So if this is just something that they are adamant about and you do not want to do, it's always a good idea to get another, or you can offer at least a opportunity for a second opinion, and some other provider can review the case as well and discuss with family members their own opinions. And so this is from the President's Commission on the Study of Ethical Problems in Medicine, Biomedical, and Behavioral Research. So informed consent does not mean that patients can insist upon anything they might want. Rather, it is a choice among medically accepted and available options, all of which are believed to have some possibility of promoting the patient's welfare. So they can't just ask for anything. It has to be reasonable and it has to be beneficial to the patient and somehow promote their healing. So just to go very shortly into organ donation, I wasn't going to go too far into this, but just consent for organ donation. So a signed donor card or organ donation form takes precedence over the wishes of any survivor. And so that if a patient has it on their driver's license and they wish to be an organ donor, it should mean that family cannot refuse organ donation. Now, that isn't always true. A lot of times, is noted, organ procurement organizations will actually forego harvesting organs if family adamantly objects. In an effort to forego harvesting organs under these circumstances, they don't want to appear to kind of the rest of the city or state that they're just stealing organs from patients when family members don't want them to. But it should be that a signed organ donation card selected by the patient overcomes all of the other wishes of family members. And we have had a case of this where the patient had a signed organ donation card, but family refused, and they actually did not donate the organs for this reason. Medicare reimbursement regulations and Joint Commission require that family or any potential donor must be asked about donation and encouraged to give their permission. So if they're going to donate, there should be a documented discussion with family. And if the patient has never signed an organ donation form, family can always decide to donate organs. So just because they don't have an organ donation little sticker on their ID doesn't mean they are definitely not up for organ donation. Family can always decide that. And just briefly, we as providers do not bring up organ donation to family members. We don't want to appear to be have some sort of conflict of interest. As physicians, we're caring for the patient, and our focus is on treatment of the patient themselves. And we don't want to be seen as coming up to the family first thing and talking about organ donation instead of talking about how the things we're doing to help their family member at this time. So in situations where brain death appears imminent or has occurred, nursing staff are the ones to notify Loop or Life Connections of Ohio as our local organ donation kind of organizer, and they will come in and discuss organ donation with family. Now, if family brings it up to you as a discussion point, you are okay to answer questions and discuss options with family, but it shouldn't be something that you initiate that conversation. Only if family begins to ask you questions should it really be discussed. And so lastly, when to consult ethics. Usually it's very rare, but there are some scenarios in which it's probably good to get ethics on board. One for clarification regarding decision-making capacity, informed consent, or advanced directives. If there is any sort of conflict with family members or the patient regarding execution of an advanced directive, or if the patient lacks decision-making capacity, you can always ask ethics to help out. They're available to provide recommendations for conflicts regarding DNR withdrawal of care, and then also to help with conflict resolution between providers and families. So if you're having these discussions with family and if you feel that it is becoming a point of contention or something you're concerned about, I think this kind of goes on to under the scenario or idea of loading the boat. So if you're nervous about kind of the discussions you're having, it might be good to get someone else on board to help with those discussions and also to protect yourself in the future should this become a problem later. And so this is where most of my information came from today. If you have any other questions or are interested in any of this, this is something that Paul gave me, Practical Ethics for Students, Interns, and Residents, that had a lot of good information and some other resources in it if you're interested in figuring out some more on these ethical dilemmas.